Shiomo. Against the motion, mostly because of lack of regulation in our setup and adolescents using it as a gateway drug to other substances. I also had a question. My question is to Dr. Tyndall and Dr. Karanja. Critics argue that introducing vape as a harm reduction strategy in Kenya would normalize nicotine use and create a new generation of users. How do you distinguish between a public health tool and a gateway risk in our context?
Very good question. You have the opportunity to respond to those ones. So, Professor Motho believes that this vaping is a gate towards cigarettes. Yes, sister, introduce yourself. Are you for or against?
Good morning. I'm Evelyn Naraka, nurse in charge Bustani, against the motion because adolescents will take advantage and abuse the vaping. In your book challenges prevailing narratives around vaping. Which one, in your own view, is the most dangerous myth and we might need to debunk, particularly in Africa? Thank you.
Thank you very much. We can get another online and also here. Yes. All right, the audience present here.
We can have one more. Yeah, nobody has to.
Right.
For or against the money?
For.
Okay, for the motion.
That's but the question, they say they are against the motion. What percentage of people who vape in Kenya are using it as a harm reduction method? What about worldwide? Do we have any statistics on this?
Okay, so we want numbers. We want some numbers. Okay, in the room, do you have any other?
Yes, we have one last.
See, I can't see them because I'm.
Oh.
All right, stand up, come near the microphone. Introduce yourself. Are you for or against?
Good morning. My name is Lillian, and I'm against the motion.
You're against the motion, yes?
Yes. So majorly because of the policy part. As much as we want to control the smoking of the older generation, it might be very difficult to control of the younger generation because we'll be allowing it the availability and they'll definitely be accessing it. So my question regarding that, because now we'll have to formulate policies to control the misuse of the vaping. So my question is, you have framed vaping as a breakthrough in the management of in the control of smoking. So what would you say to policymakers in Kenya who fear that it might erode the hard-won gains in tobacco control?
Thank you very much. Now, did you have any invited speaker commenters from overseas or locally? Sorry?
What?
Sorry?
I didn't hear that last part.
No, I thought we had invited special comments from people from the UK or from the US. Although I am told the UK doctors are on strike, I don't know whether they want to do that. Put up your hand if you'd like to make a comment on the online audience. No. As we are checking on that technology, we'll take one or two more comments.
And we have Dr. Kariuki, the head of harm reduction in Kenya.
Dr. Kariuki, you are most welcome to make your contribution in these matters. Kindly introduce yourself and let us hear whether you're for or against. Dr. Kariuki?
Oh, hello. Hello. Good morning, everybody.
Very good morning.
Yeah, thank you very much. My name is Dr. Kariuki Michael. I'm a consultant pediatrician, epidemiologist, public health expert, and I'm the Secretary General for Harm Reduction Society of Kenya, an organization that we formed to spearhead harm reduction initiatives in tobacco, pesticides, cannabis, and such related issues pertaining to harm that most of our countrymen in Kenya go through. Let me say that I'm for the motion, and I'm really elated to be part of this discussion. It's a discussion that we have been spearheading for quite some time, and it's great that we have reached such level whereby now we are open to such discussions, because these are things that we cannot run away from. Science is very clear on the role of e-cigarettes in tobacco harm reduction, as evidenced by Cochrane. We all know from studies that these reduced risk products are 95% safer than combustible cigarettes. And we don't even need to look further. If you look at the UK, they have implemented a very pragmatic strategy, which they call swap to stop, where they encourage their combustible smokers, those who use combustible cigarettes, to switch to e-cigarettes. And it is a program that is run by the UK government to try and reduce the smoking-related illnesses. Just to mention, smoking cigarettes or cigarettes are the only products which, if used correctly, will kill you. And 50% of tobacco users will end up dead. So this is something that we cannot ignore, we cannot run away from. There is overwhelming evidence out there. We have a lot of myths and misconceptions that need to be debunked, and they already have through science. And what we are trying to say is that in this country, we need a lot of regulation. As we speak, there is the Tobacco Control Amendment Bill, which we are participating in to try and regulate. Because I did hear one of the speakers say that indeed we need regulation, because some of these products that are coming out there are very high nicotine content. And we
Thank
need
you
to
very much, Dr. Kariuki. I think we must move on. And it's very clear that you have a lot of evidence in support of your position. I see Professor Muthoni Maathai, a teacher at the University of Nairobi, has a hand up. Could you unmute Professor Maathai?
Thank you. Can you hear me?
Clearly, go ahead. For or against?
Thank you very much. I am for, as a lived experience.
Go on.
And I know that vaping has saved lives. And I say this with that knowledge that, of course, adolescents will take advantage and use it. But we even have laws against them buying cigarettes, and they buy. We have laws against them buying alcohol, and now we even want to raise the age, but even 16-year-olds are buying and using. So that problem with adolescents is for policymakers to find ways to regulate that, but that should not kill a good initiative. And so I think I am very much for.
Okay, so we'll accept 2 votes from you because you're a teacher.
Thank you. Why didn't you take the lived experience to add me 2 more votes?
Okay, then you have 3. Thank you so much. As we see on TV, this house is really on fire. Yes?
And we have one from Rwanda.
One from Rwanda.
Yes.
Sorry?
Yeah.
Against, okay. So what is the name of the person from Rwanda? Oziel. All right, let's hear from you, brother or sister. tell us if you are for or against. Dale, can we hear you? You have not unmuted yourself, Uziel. Gaboni will unmute your mic. As we deal with, oh, and then you have Chibanzi.
Can read his comments.
Sorry?
You can read Uziel's comments.
Okay, read his comments.
All right. So
This is the comment from Rwanda,
yes,
and then we will have Chibanzi.
I am against vaping.
You're against vaping, go on.
Best interest of health promotion.
Speak up, please, Mr.
All right. So Uziel from Rwanda says he's against vaping for the best interest of health promotion. Yeah.
Is against vaping, thank you very much. Please unmute Chibanzi. And then I will ask a special guest, Simone, who will introduce himself. Simone is sitting, not just here, let's hear from Chibanzi. Go ahead, Chibanzi. Have you unmuted him?
Yeah, good morning.
Good morning.
Yeah, I'm against the motion for 3 reasons.
Motion, very good.
One is that there's increased risk in the younger population, in the youth and adolescents, and more specifically in a country where regulation is very poor. Then the second reason is there's research that has shown that there are known chemicals in the aerosols used in vaping, and these are a significant risk factor. So it doesn't give much of a difference as to cigarettes, which also has several toxins. So this research is one that would promote use that would make people expose themselves to what we don't really know, because the chemicals are yet to be identified fully, and the impact on health of those who would vape. And then thirdly, the third reason is that we cannot say that we'd allow it for those who, sorry, the third point is that the long-term adherence to vaping is not yet known. Most of the studies that have been conducted actually show that a significant number of those who go into vaping eventually go back to cigarette smoking, because at the end of the day, both vaping and traditional cigarette smoking still deliver the same component, which is nicotine. So the addiction part has not been shown to be fully eliminated using vaping as opposed to normal cigarettes. Thank you.
Thank you very much. And Simone, introduce yourself and tell us whether you are for or against.
So I'm Simone Gassim, I'm a documentary filmmaker, so I'm not a scientist.
You're a filmmaker, you make films.
Yes.
Like movies.
Exactly, documentaries, especially.
Okay.
Mental health and advocacy here in Kenya, especially. So I'm not a scientist, and I'm very interested in listening to the different positions. Of course, this is the debate that is going on also in European countries and
Which is your country?
Italy.
Italy.
Yeah,
Very good.
country of origin.
And the city of Pisa.
At this point, I would say I'm in favor of it.
You are in favor?
Yeah.
Good. Thank you. Yes, go on. We'll indulge ourselves with 2 comments, Gadoni. Who is this from? These are online participants. Read it, Gadoni.
I think it's better we display.
Okay. For us, Gadoni, time is against.
David Mongai says that combustible cigarettes are harmful because of toxins. The idea of harm reduction is to reduce this risk by offering safer alternatives for nicotine delivery, which is what vaping e-cigarettes aim to cure. The issue of teens and adolescents are introduced to vaping early is a regulatory issue. Remember, they still get introduced to smoking too. The amount of nicotine in vapes can be measured and clearly labeled, enabling regulation. I support vaping as a strategy for harm reduction.
Last comment.
We have one against.
Go on.
Please go down. From Catherine Gitao. She is against the motion. She says, I would like to understand, once we encourage people who smoke to vape, will this be a lifetime habit? Does that mean that there are no other interventions going forward? With methadone, there are control measures. What would control measures look like for vaping?
Thank you very much. We are really strictly adhering to time. So we are now coming to the end of this conversation. And as is tradition in this kind of debate, we will reverse the order of speakers. I'll start with my right with Dr. Joseph. I will then go to Dr. Karanja, Dr. Judy, and Dr. Tyndall will give us comment. Each respondent now has 3 minutes.
2 minutes.
Oh, give them 2 minutes.
Yeah, but we can do 3.
Let's do 3. Yeah, because Dr. Joseph also spared 2 minutes. So
Yes.
we'll give you 3 minutes starting now.
Yes, I wish I could have gotten my 4 minutes.
Yes,
okay.
Yes.
So first and foremost, I'll handle the issue amongst teens and adolescents. When you talk about introduction to vaping, we're talking about it in a matter that it's much easier for them to be introduced to vaping than to be introduced to cigarette smoking because of how they come with a lot of different flavors and they come with different shapes and sizes compared to cigarettes that look very mad. The other thing that I would like to talk about is the European Respiratory Society say that any harm is harm. So we're not talking about risk reduction, we're talking about risk elimination, especially in some populations, including people who are pregnant, don't want to reduce risk, you want to eliminate risk. People who are also adolescents that were spoken about right now, they're also a risk population. Don't want to reduce risk, we want to eliminate risk. I would also like to discuss about the issue that Dr. Karanja brought up about the ritualistic nature of the cigarette smoking and vaping. We would like to say that some people have come up with the better options. Some also just use straws. Some also use nicotine cigarettes that have 0 nicotine at all. So that can also be helpful in the ritualistic nature. I would also like to discuss issues around the realistic way of us using nicotine vaping. We have better realistic methods. We have tablets that can reduce risk and that are better harm reduction strategies. We have the patches and we have the gums that are better than the vaping in itself because we have discussed the components of the vape itself. We don't know what the components are, and there are not enough longitudinal studies that show how long these components are causing harm. And finally, I would like to talk about the risk of pulmonary disease. We know it reduces risk of probably cardiovascular disease, but we're not sure about its risk on pulmonary disease. So people with COPD, people who have infections, the higher risk of infections, because the nicotine in itself, despite having less components of tar and everything else and other issues, it still causes problems amongst pulmonary disease. When we talk about ethical frameworks, we live in a society where ethics is really a difficult situation to handle.
Don't insinuate anything about that.
This is my opinion.
Okay, all right.
Not the opinion of the people who are holding this debate, but still it gets difficult for us to regulate. And if you're not able to regulate, then let's just not try at all. And that is rest my case from there.
Okay, you can rest now. Dr. Karanja,
Right, thank you.
you have 3 minutes.
Right. So I will start by reminding us what is our scope as healthcare practitioners. And if we look at the guiding principles of the practice of medicine, we forget an important one, that is autonomy. And we risk moralizing an issue. Remember, nicotine is not an illegal substance, it is legal, such as alcohol and cat. So who are we treating? Are we treating our own conscience, or are we treating our patients and the people who are smoking? So we must step away from moralizing vaping as good or bad. The other thing is we need to zoom out and look at the present harm that is happening to people. It is unacceptable for our patients to be dying 15 to 20 years earlier because of a remote possibility that children are going to take up vapes. And we are mixing issues. We are mixing the issue of regulation and enforcement with the issue of harm reduction. The other issue is about our frameworks. How well are we able to implement the laws? And Dr. Kariuki talked about the National Tobacco Control Board pushing an amendment that seeks to regulate vapes. Some of the things in there are really good. They want to limit the amount of nicotine in a vape pen to 10 milligrams. It should not be advertised anywhere. It should not be hawked. Social media influencers should not be allowed to market these products. So the onus is not on us as healthcare practitioners to stop children from using substances. It is to protect the millions of people who are dying from cancer right now as we speak. And it is for the rest of the government institutions to ensure proper regulation and enforcement. So we can't bury our heads in the sand, and we can't tell our patients that they should stop using nicotine because we want them to stop. It is a legal substance. They can use it if they like. We have a duty to prevent harm from the use of nicotine.
Thank you. Right, the fire continues. Dr. Judy Kamal, you have 3 minutes to wrap up this conversation from your side.
Yes, we can tell our patients would not want them to use nicotine because it's harmful to their health, and we would rather they did not use nicotine. So that is also our role as health advocates, to push that agenda because it is harmful to your health. However, also with vaping came the idea that it did not have much of any negative health issues in the past, but then over time, we're starting to see a lot of, especially lung challenges, gives you inflammation, lung disease, even if it is coming with a space of harm reduction. So, and sometimes it's hard to regulate the amount of dosing that you can use for with vaping. Unlike maybe because we've compared it a lot with methadone, unlike methadone where you don't get the extreme high that you would still get that from a nicotine, from e-cigarettes. So you still get your kick from off your nicotine. It does come in higher and higher doses. So if someone is trying to sometimes even start to quit smoking, they might find they're using even more nicotine than they used to use if they're just coming from a space that I'm quitting cigarettes because it's I'll less likely have cancer. We are seeing as much, someone did ask about longitudinal studies. We haven't had them yet, but we are seeing chemicals in vapes that would increase your risk to having cancer. Yet, yes, we haven't said that it is directly causing cancer. That is still under study. But we are seeing chemicals that are in vapes that, that can increase your risk to getting cancers and all of that, and also has increased risk in cardiovascular disease, in lung issues, just like any other nicotine, like the tobacco-related nicotine. So biggest challenge, of course, is regulation. We have had problems in our country. We will not say that we cannot ignore that as a fact. But yes, there is higher access, and we'll be having now to deal with how to quit vapes. Well, it was a problem that we didn't really want to have in the first place.
Thank you. Okay, excellent. Now we have the final comment from Mark Kendall.
Okay, thank you very much. I didn't realize coming into this I'd have such a great partner, but many of the debate points that are brought up, especially from the no side, I cover in my book, Vaping Behind the Smoke and Fears, and I try to bust a lot of the myths that have come up in this conversation. So I really like the point that risk reduction in youth is really a separate issue from offering a safe alternative to 1.3 billion people who smoke cigarettes. And we struggle a lot with trying to prevent risky behaviors among youth, whether it's alcohol or cannabis or teen sex or video games or whatever. Like these are issues about risk of youth that we'll be continuing to deal with. And I think we need to do a better job of education and regulation. But vaping somehow now stands out as one of the biggest risks to our youth. And clearly it's not, as far as the actual use of nicotine. And the indication that this is a gateway to cigarettes has been totally disproven. So we've had it long enough now. In North America, the rates of vaping peaked in 2018, and the rates of smoking are at historical lows. So cigarettes are kind of finished for youth in North America, and I think that will happen around the world. And the kids that would smoke maybe are now vaping, which is a public health win, because we'd rather them use a much safer product than cigarettes. As far as it's too early to tell, and there's no longitudinal studies, that's not true. I definitely am a researcher and believe that more studies is necessary, and we should be doing a much better job of tracking things. But after 15 years of fairly widespread use, there's really no indication of lung disease, cardiovascular disease, or cancer with vaping nicotine. Now, clearly there's a lot of bootleg and unsafe, unregulated products that have come onto the market, but commercially regulated vaping nicotine, there's no evidence that it's a detriment to your lungs. And certainly compared to cigarettes, it's nowhere near. And when you compare the number of chemicals in vaping nicotine to cigarettes, most of the chemicals are not there. And the few that are in concentrations that are so tiny that they couldn't possibly be clinically significant. So without a doubt, this is way safer. It's not a gateway. We've proven that. And many of the other myths that have been come up during this debate, I think are very good questions, but I cover many of them in my book, and I've come to the conclusion that vaping is the answer to a century of preventable death and disease, and we need to get.
Thank you, Mark. Thank you very much. Why do you look so restless? You're not restless. Okay. So I think we've heard from both sides, and we are very grateful to all who have shared their voice in this big debate. The correct thing for us to do now is to do a poll, an online poll, to see who has shifted and who has not. And then after that, I will have one or two things to say myself, and then we'll on from there.
Just to give an overview of the motion for anyone who joined us late, this House believes that vaping is a harm reduction strategy worthy of immediate adoption in Kenya. So for our online guests, you can, good job.
Vote, yes.
And for the live audience, still the same.
No, we must take a separate vote.
Okay.
So that one is going on.
Yes.
All right. Take another vote now, yeah?
Yes. So those who are for this motion now, please.
So those who believe that this House,
yes,
that vaping is a harm reduction strategy, not a good thing, not a bad thing, but a harm reduction strategy worthy of immediate adoption in Kenya. Up with your hands, please.
Lovely. So that is.
Yeah. Okay. Right.
Yeah.
And those unmoved by those who say this House believes that vaping is a harm reduction strategy worthy of immediate adoption in Kenya.
Yes.
Against. Judy, I can see your hand. Will count you as well. Yes.
9, 10. 10, yes.
Okay. Okay. In this House, what is a shift? In this move, rather.
10.
10. It has moved by a factor of 10.
From against 4.
Then?
Yes. And for against. So before we had very few, 3, 4. 3 and 13 against. After we have 13, 4 and 9. And 10 against.
Okay, and online?
Online we have, before we had 14%.
14% for?
And 86% against. And right now we have 46% for and 54%.
So the house is divided.
Against, yes.
The house is divided.
Yeah.
And even this one is pretty close.
Yeah, very good.
Now, that typically is the intention of a debate at the Maudsley Hospital. We come without preconceptions. Mostly we come with open minds and closed mouths. And we leave with clarity of thought. If the debate carried, when you add in-house and online people, who's the winner? George?
So from our online audience.
No, total. Online are real people as well. It's close. It's close. And you can include people from Rwanda.
Yeah.
Yes. So this house believes that vaping is a harm reduction strategy worthy of immediate adoption in Kenya.
Agree. I still disagree.
All right, well, they're doing the math. I have something I'd like to address with you this morning, which is a point that Dr. Kariuki and Dr. Karanja have mentioned, which is the fact that this thing is live in our parliament. It's completely alive. Look. Yeah. There's a Senate bill that was published on the 1st of July, 2024. Yes, right in the middle of the Gen Z Manenos, which received its first reading in Parliament, our Parliament, on the 6th of August, 2024, and is currently in the hands of the Standing Committee on Health in the Senate. So this is not an idle conversation. This is a real and proper and valid conversation. The bill seeks to amend, as Dr. Karanja has said, to amend the Tobacco Control Act of the year 07 and intends to address the gaps that exist from the year 07. It's a job of Parliament to do this kind of work. It goes on to define certain terms like addictive behavior, electronic cigarettes, and that sort of thing. It speaks to the Tobacco Control Fund, which is a fund that people who manufacture and so on sell cigarettes have to pay into. It speaks to who is responsible for regulating the whole matter of vaping. And that responsibility, if this matter is considered and approved by the Senate, will be the Cabinet Secretary, for the time being in charge of health. What is really interesting, and I really would like all of you to look at this, is the last provision in this bill, which says the following. This question is answered. So what is expected from members of the public, which is ourselves? This is now from the Senate. The Senate requires of us, the members of the public are expected to present their views to the Standing Committee on Health for consideration. In other words, what we have done here today is 100% valid. It is in keeping with our constitution which demands that any law that is up for consideration in Parliament should be subjected to public participation. So this is a live matter. It's being considered. This is not a matter of banning or not banning vaping. This is a matter of regulating the whole process of vaping. Having said that, if the Senate, the Parliament is like this House, we'll probably end up with a divided House, which cannot necessarily be a bad thing. Before I ask Mark Tyndall to say some words, maybe you can hear the results of George.
So when I combine all the results, we have 55% against.
55% against,
Yes.
okay?
54%.
So 1% is dead.
Yes.
Okay, all right, so Judy Kamau and Joseph Nyamiobo, makofi kwenyu. Asanteni sana. Right. At this point, I am required to introduce Mark Tyndall again. Now, not as a debater, because you have been defeated soundly in this debate, and we shall not repeat this debate. But just to tell us a little bit about himself, how he got into Kenya, where he worked and with whom he worked, and how a physician, particularly in infectious diseases expert from Canada, finds himself back in Kenya 25 years later to discuss the most unlikely of events, which is harm reduction. So maybe, Mark, you can take us through your career. I think it's interesting. Okay. It's the kind of thing we like to hear, and introduce your book at the same time.
Great. Should I turn my chair around and talk to people or do it on here? So
No, the online community is also big.
Okay.
And they can see you.
Okay.
People behind you can see you.
Excuse my back. So thanks, Frank. I mean, 2 weeks ago, I would never have pictured myself sitting here actually. So I'll go back to the beginning. I was trained in medical school, and my aspirations was global health. So I was interested in travel and working in less developed places. And in 1982 is when I began medical school. I know I don't look that old, but it's true. And HIV was coming. So basically my first month at medical school was when New England Journal started publishing articles about strange infectious diseases in gay men in San Francisco, New York. And my career has really followed HIV. So I became interested in, my first clinic was actually in hemophiliacs who were infected with HIV through contaminated blood supply. And very early on in my career, I saw young, otherwise healthy people dying of something that we didn't even have a diagnostic test for. I then did my infectious disease training in the University of Manitoba, and they already had established clinic and collaboration with Kenyatta University and people here to look at sexually transmitted infections in Kenya, with the focus on chancroid. That was the disease that I came to study in Kenya. So part of my infectious disease training, I was assigned to do a research project at the Special Treatment Clinic on River Road, and I worked there for 2 years. And now looking back, really historical times in the world and infectious diseases. And Sub-Saharan Africa was the center of very high rates of HIV transmission. And sitting in that clinic, it was kind of life-changing. I hadn't experienced, I'd never lived in Africa before. There's lineups of people with sexually transmitted infections. It's around 1990, 1991, we began getting testing for HIV. So at one point, you know, at the special treatment clinic, there was like 1,000 people a day lined up there, and 30% were HIV positive and had nothing to offer them other than maybe have some antibiotics to treat their sexually transmitted infections. But I just gave out condoms. So I became kind of a condom doctor because, you know, I can here's some antibiotics for your gonorrhea, but man, you know, you're lucky this time you don't have HIV, but if you continue to expose yourself like that, I think this is what's going to happen to you, and you need to use these condoms. And looking back, amazingly, that was frowned upon. So church groups and governments were not very supportive of condoms. They thought, like vaping, that it would encourage young people.
That debate is finished.
Yeah. They thought it would encourage young people to have sex. And so imagine being in a situation where people and who were at high risk of HIV and fairly quick death being not being offered condoms because somehow we thought young people would get the wrong idea about sex. It's in retrospect, it's preposterous, but that's what I was up against. And I've had a lot of conversations with church groups and government officials that, look, we have to give out condoms, as many as we can get, because HIV is spreading rapidly, and a lot of young people in your communities are becoming infected. And so it seems, looking back 40 years, it seems pretty nuts that we had that conversation, but that was a real conversation that we had. So I worked in, I worked here for 2 years. I met the great Frank Njenga at that time, who was also interested in HIV. I'm not exactly sure the first time we met, but Frank opened up a whole other world to me. So I, you know, when you come over as an expatriate working in a clinic in the research, you basically, you know, your social life is around expatriate people. And so Frank was able to open up doors for me and introduce me to people that I would never have the opportunity to have seen, and hanging out at the Muthega Club and things like that. So it was really a special event for me to meet Frank and many of his colleagues. And so and then about 1992, at an AIDS conference, I met a guy named Jonathan Mann, who was the head of the global program for AIDS, and he was going back to Harvard to take a professorship there. So I decided fairly quickly that I wanted to do more research training. So I went to Harvard and did a PhD in biostatistics and epidemiology. So from Kenya, I moved there, and as part of my thesis work, I moved back to Kenya for another 2 years. So in 95 and 94 and 95. And continued to work at a special treatment clinic, and was and published a lot of very important research along with my colleagues Frank Plummer and Stephen Moses, and there was a whole group at the University of Manitoba and colleagues from the University of Nairobi, and we were at the cutting edge of a lot of HIV work. The famous Pumwani prostitute study, where there was a group of women working in sex work in Pumwani who weren't infected despite massive amounts of exposure. And they thought they were the key to vaccines and how to prevent HIV. And that key was never unlocked. So 40 years later, it's still a mystery why a large group of women who were definitely exposed to HIV never became infected. So that was one project I worked on. I then went back to the University of at McMaster University in Canada, and kept my connections in Nairobi going, and would fly back and forth several times a year to work on studies and continue to do my research. And then about the late 90s, I had 3 young kids at home. My wife wasn't that keen about me traveling back and forth to Kenya, so I stopped my work here and haven't been back until now. I then went to Vancouver and started working with HIV prevention among people who injected drugs. And I referred to that earlier. I got into starting needle exchange programs and supervised injection sites and methadone programs, and really got heavily into harm reduction and did a lot of research and clinical work in that. And then around 2012, I had a group of people. I became the head of infectious disease at the University of Ottawa for a few years. And so I moved to Ottawa and I established a cohort of people who I was following for HIV and drug use. And we were looking for endpoints. And it came quite clear to me as we followed people longitudinally that they weren't dying from HIV anymore because they were on treatment. They weren't dying from hepatitis C because we had good treatment. They were all dying from tobacco-related causes. So people, when we checked off, the death certificates at the end of each year, more and more people were having, COPD and lung cancer and had strokes, and it became clear to me that it was all smoking related. And I wasn't offering them anything. I was offering them HIV medications, but they were dying of HIV. And when I heard about vaping, I started introducing that to some of the cohort, and they took it. They liked it, and they felt better. And I thought at that time, man, this is like a revolution. We can, really stop all this needless death from tobacco. Little did I think that, 10 or 12 years later, we'd be having these debates about flavors and youth, and like we're sitting on the cure for tobacco, combustible tobacco, and somehow we're being sidetracked by things that we shouldn't be sidetracked on, and we owe it to people to give them the opportunity for a safer product. And that goes for all my harm reduction work. I owe it to somebody to offer them a clean needle. I owe it to them to give them a condom. I owe it to them to offer them supervised injection sites. I mean, this is just, in my mind, the only ethical approach I can take to people's health, because I can't stop them from risky behaviors, but I can stop them from dying from those risky behaviors, and that's where I'm at. So I did work with drug users for 20 years. About 3 years ago or 4 years ago, I was head of the BCE, the British Columbia Centre for Disease Control, which is a big public health agency in the province in Canada. And one day I had, this is maybe too much information, but I had a pretty severe mountain bike accident. And I was in hospital, I broke a lot of bones, and I had a punctured lung and some heart contusions. And I was lying there wondering if I'd ever do this again. Like, what was my life going to be like after this accident? And how many years do I have left? And I quit my job, and I decided life's too short. I don't want to die working. Or working at what I was doing. So my wife and 12-year-old son moved to Bali, Indonesia for 2 years. And there I kind of went on a long self-discovery, self-healing process, and did a lot of yoga and meditation, and really tried to do some reflection. I wrote the book during that time. And so, yeah, it was life-changing. But during my reflection there, I look back often to Kenya, and how pivotal that was in my whole life trajectory, and how important it was to, who I am, not only my career, but personally. And then I did a book launch in Warsaw, Poland in last month. And I talked about Kenya during my harm reduction comments. And a woman came up to me and said, "Oh, I really appreciate what you said about Kenya. And we're having a tobacco harm reduction meeting in Mombasa at the end of the month. Could you come?" And I said, "Well, it's a very long way, and I'm just going to be back from Europe." And then that night, though, I sat up and thought, I gotta go. Like I haven't seen Frank and Jenga in 25 years. Like I have to go. So that's why I'm back here. I'm going next week to Mombasa to help with this. There's a whole network in Africa. Apparently, I don't know too much about it, around harm reduction and tobacco harm reduction. So I'll be there and to promote my book, but more so promote the idea that we really have an opportunity globally, but places like Kenya where we could quickly improve the health status of the population, and certainly the people who smoke cigarettes, if we offer them something safer. So yeah.
Thank you very much. Okay, good. Well done.
And I have 5 books left, if anybody.
They're mine.
They're yours.
I will distribute them the way I want.
Okay.
Dr. Gumbo, do you want to thank our guests? And then I will ask Simon to say something about himself and the work that he does, and then we'll start. Dr. Gumbo?
I'm Dr. Gumbo from Chiromo Hospital Group. I would like to thank everyone who's made the time to come in, and our listeners from online, and warm appreciation to our presenters. You had us on the edge of our seats with wonderful insights on the debate. I'd like to thank the chairman for giving us this forum, and I would like us to have more discussions of the same. So thank you, everyone.
Thank you very much. Right, this gentleman now go on, stand up, Simon. I met him earlier this week on Monday. I did know him from Adam. I met him through the courtesy of another friend who I don't believe you met, Professor Sloan Nafon, professor of the history of medicine, technology, and related matters in the University of Oxford, who, like you, I worked with 15, 20 years ago here in Kenya. Her special interest was the history of the Mau Mau and how the whole history around the Mau Mau evolved. She worked with another friend, Professor David Anderson, who was also professor of history in Oxford, who has written the most authoritative book titled The Histories of the Hanged on the Mau Mau. And what Sloan is doing with our team is they're developing a bit like Mark has said, interests shift with time. So her interests have gradually shifted from the history of medicine and Mau Mau to epilepsy. And she's doing a lot of work in Kilifi, which is what Simone will tell us about, on epilepsy in many parts of the world, including Kenya and so on. So that's a context in which I met Simone. Simone, in the next 2 minutes, can you describe what work you're doing in Kenya?
Yeah, sure. So I'm a documentary filmmaker and
filmmaker.
Yeah, I've been working here in Kenya for the past 15 years, especially on applying documentary filmmaking to the research context in different areas. Recently, in the last 5-6 years, I've been working with Professor Mahon, with the Oxford team, on large research projects, especially on epilepsy in sub-Saharan Africa. Of course, Sloan Mahon works on a oral history program, which is a kind of innovative approach. And in this project, we have like a multidisciplinary team where I work side by side with scientists and other researchers. And of course, my task is creating content for advocacy, awareness, both at the community level, but also to reach out to decision makers, like campaigns, national campaigns. And so, yeah, that's basically what they do. And I believe the power of storytelling, to focus. So that's my job.
So, Gavani, he has offered to help you and your team in the documentation of the work that you do. Dr. Gumbo and I were able to describe to them the kind of work that we do with lived experiences. And so he's your guest today. All right, and tap your brain and his resources and see how you can benefit from that.
Thank you.
Right, we have come to the end of this morning's debate. I will now make the following announcement. One book goes to Dr. Karanja, another one to Dr. Nyamiogu, the other one to Dr. Judy Kamau, and then there are 4 books.
5 left there.
Yeah, no, what? No. Oh, there are 5 left. The vaping expert, Dr. Kibuti will get one. And I will be left with one so that I can decide on my favorite. All right, so they will tell you their names.
And I'll
we'll
sign
send
up
the
by
book
them.
for them. And that brings us to the end of.
For those unlucky enough to get a free copy.
Yes.
You can order one.
You can order.
They're on Amazon.
They're on Amazon. Thank you very much, and thank you for a stimulating morning. Have a good day, and I hope we work well. Asanteni sana. Goodbye to you, virtual audience. Your participation has been highly appreciated. Thank you and have a good day. Bye-bye. Also, the last one must go to Zawadi for organizing always.
Okay, where they?
Well, it's Zawadi is going to class.
Okay.
We have many classes. Okay.
You want me to sign it?
Thank you. You may sign it. And well done.
Just, yeah, tell me your name. TH. Sorry.
Welcome back to Africa. Thank you. And well done for winning the debate.
Oh, thank you. I think at that one, I think they might have said that.
Good. Thank you for your book.
Because I can.
These sections are not. Don't accept. They were not free, they were not. Must convert you.